Okay, I have no disclosure. Thank you. This is a 49-year male meningococcal septicemia in emergency. There was an increasing unwell. Over 2 days, collapsed with reduced level of consciousness. On examination, he is hypertensive, shocked. Lactate was 5, little high. Bicarb was 15. And the resuscitation was done in the ER and then in the ICUs with some fluids and noradrenaline, and it increasing more than 15 mics per minute. Uh, quickly, we were being called for this echocardiography, and you can see. Can you play this, please? Oh, so you can see it's a mildly dilated kind of an LV in parasternal long axis view, and you can see it's a moderately reduced ejection fraction around 40-42%, and you can see over here that the EPSS is on the higher side, but you can also see that there is some dilatation of the RV also. So it's a moderately global reduced ejection fraction. Can you play this? Okay, this is the short axis view at the 3 different levels of mitral valve at mid level and apical level. You can appreciate this moderately reduced, and there is some dilatation of the RV also you can see over here. Diastology. The lot has been talked because my topic is literally kind of an overlooked or underdiagnosed kind of dilemma. You can see over here that there is some parameters of diastolic heart failure. In this case also, E over A is around more than 2 E over E prime, and LA volume was within the normal limits, but TR velocity was 2.9 meter per second. And you can see over here also that E prime is around 5, which means that E over A, TR velocity, and E prime, they are 3 in the number. So probably there is some kind of a diastolic dysfunction with the normal LV filling pressures. Considering the right, I said in the previous slides, we see that the RV is little dilated. So the RV, the function of the RV is definitely depressed, which TAPSE shows of 11 or 12 or 13. The IVC you can see over here is non-collapsible. Patient is definitely intubated, and in the setting of a ventilated patient, what I need to mention here when we are doing echocardiography in septic or ventilated patient, rather than the IVC collapsibility, we should be looking for IVC distensibility index. And what it is, that IVC distensibility in septic shock predicts if a patient will respond to fluid responsiveness, especially in the mechanically ventilated patient, where a value over 18% suggests that patient should have a fluid response and they will respond to the fluid. A higher distensibility indicates better IVC compliance and greater fluid responsiveness. So it has a limitation like a PEEP and the RV dysfunction, but somehow it is a great modality to see in the setting of an ICU. So what is the formula of an IVC distensibility index is simply you have to know that ventilated patient, there should be an IVC of maximum in the end of expiration and end of inspiration minus IVC over the minimum side, multiply by 100. And if it is the index of more than 18% and or even the 13% suggests that the patient will benefit from the fluid. A higher baseline in the distended IVC and significant decrease after fluid bolus often identify fluid responders guiding resuscitation in the resource limiting and the settings. So what were the thoughts in the first case? This is the conclusion of the LV dilatation, LV systolic and diastolic dysfunction was present, RV dysfunction was present. So the thoughts were here that probably there is a pre-existing disease, but patient was a 49-year normal ECG, just a sinus tachycardia. There was less likely myocarditis was normal, the serology was normal, meningococcal myocarditis was rare, but there was a suspicion, and they gave the diagnosis or differential of the septic cardiomyopathy, and most likely early antibiotics, resuscitation, avoidance of the more fluid overload or inotropic supports. 51-year female. Again, next case I'll explain the both. The community-acquired pneumonia, septic shock, ARDS, day 2 persistent hypertension, NORAD or milrinone, poor capillary refill. You can see the X-ray. Oh, sorry. So can you play this? So please play this. So this is the thing which we used to say, and probably we overlook it or underdiagnose these kind of LV when the patient is in the shock. You can see a parasternal long axis view, and you can see some pulmonary congestion of pleural fluid over here. but the LV size and LV function seems to be normal. Please play. So if we see this four chamber view slightly more, that you can see that the right side of the heart is almost equal to the left side of the heart. You can say that RV has to be less than the LV, but if you find that RV is probably equal or mildly dilated than the LV, then definitely there is an RV strain. You can see a TAPC over here, which is 15, which is a kind of a moderate kind of a RV function. And this is the thing which needs to be seen in all the ICUs, and specifically mechanically ventilated patient, which I will emphasize on this talk, is stroke volume variability. This is a pulse wave Doppler at 5 chamber LVOT, and you can see a different stroke. Please back. Okay, sorry. So you can see over here that these are the stroke volumes at different levels. But you have to be, there are some limitations for stroke volume variability, but these, if there is no other parameters than the stroke volume variability. This is the thing which we need to see, that in the patient of the septic shock, they are fluid responsive patient because there is stroke volume variability. So thoughts were that there was this response to vasoplagia, normal LV filling pressures, the fluid status, passive leg response needed for give IV fluid more if positive. There was a mildly, because in the setting when we say that there is a patient which has a reduced RV function, in our case, even the minor fluid overload could be costly. So we need to be very much cautious about in the setting of the fluid status, lung ultrasound, a dense consolidation. So the main emphasis of this hemodynamics variables at 0 and 24 hours of this patient, you can see the mean arterial pressure is 73 at the 0 hours, and it definitely increased to 24 after 24 hours of 76. The most important, the stroke volume variability, from it was 13.6, and after the 24 hours it was only 10.8, which is less than 13, and very significant that you should not be giving excess fluid for these septic patients. You can see the arterial lactate level in 3.9, and which is reduced to 2.3 after 24 hours. What is stroke volume variability? So this is the take-home message. I believe that that measure during the mechanical ventilator is a key dynamic indicator for fluid responsiveness. It shows how much stroke volume changes with breathing. A high stroke volume, more than 13%, like in our case, suggests that the heart needs fluids to improve. A low stroke volume means that heart is already full on the flat part of the Starling curve, and fluid might cause harm and organ edema. Usually you used to, when a patient agar hamara land karta in emergency and you are called for an echocardiography, in a 30 minutes time and a 1 hour time, एक 2 से 3 लीटर फ्लूइड दे दिया जा चुका होता है, और फिर बात की जाती है कि जी अब आप देख लें कि ना पेशेंट को अब फ्लूइड ओवरलोड हो गया है. So there is some mechanism even in the ER or as ICU setting or even in the CCU that how much fluid patient needs and how much it should be given. And if there is the stoppage of you cannot give even more fluid, then the treatment paradigm should be shifted to some inotropic supports. So there is a threshold that of 10 to 13% typically indicates a patient to fluid responsive. In mechanically ventilated patient with septic shock, stroke volume variability generally shows a high accuracy for predicting response to the fluid loading. It has a superiority. You know the concept of the CVP and IVC and even the mean arterial pressure, this stroke volume variability has taken advantage and more reliability than the CVP and the other clinical parameters. It helps prevents over-resuscitation. If we only follow a stroke volume or lung ultrasound, the over-resuscitation we can avoid, and we can avoid the pulmonary edema which we are giving in the patient in the ICUs and ER with excess fluids. There are some limitations, as I mentioned, that the patient in the RV dysfunction or arrhythmias, but definitely it prevents worsening of the LV-RV dilatation and pulmonary edema, and supports early shift from fluids to vasopressors. So the low stroke volume, definitely, when there is a low stroke volume variability, it suggests that patient has less likely to have a septic shock, and it suggests that patient might have a cardiogenic or other, you can say that obstructive kind of shocks. This is the next thing which I need to emphasize is LV stroke work index. This is very important and very easy to calculate. You should be calculating right like on your mobiles. You only need to have this limitation that we all know that how to calculate this stroke volume by calculating this LVOT area, then LVOT VTI, and after stroke volume, you just divide by a body surface area for stroke volume index. E over A, we all know diastology has been talked a lot, E over E prime, and you just multiply your E over E prime with 0.62 and then add 4.9, that will give you an LV and diastolic pressure. And mean arterial pressure you should be knowing after systolic and diastolic blood pressure. So how to calculate a stroke volume, LV stroke work index? This is a simple formula of 0.136 multiplied by stroke work index, and then mean arterial pressure minus left ventricular and diastolic pressure, because and it gives you a value of more than 25 mm per meter square. It means that it has a normal. In septic shock, the LV stroke work index is a comprehensive hemodynamic parameter that integrates both systolic and diastolic performance by measuring the work of the heart performs during each beat relative to the body surface area. So it emerged as a superior prognostic indicator compared to traditional LV ejection fraction. You can see over here, very important thing, a low LV stroke work index on day 1 is strongly associated with increased 28-day and 30-day mortality in large 2025 multicenter of over 1,300 septic patients. Each standard deviation increase in LV stroke work index was linked to a 30% reduction in the mortality risk. So it has an L-shaped relationship. It has a high-risk patient. It has a stable risk, superiority over LV ejection fraction. I will not go into the details, but it definitely shows a superiority over LV ejection fraction. It also determines the risk stratification. LV stroke work index provides incremental value to standard severity scores. So LV stroke work index is directly to sequential organ failure assessment and Apache 2, helping the clinicians identify high-risk patients who may require different therapeutic approaches. So role, definitely we all see whenever you go to an ICU ventilated patient, you don't get all the time a proper apical chambers or proper views. Probably you just have to find a subcostal view. You can see an hyperdynamic RA, RV, LA, LV. So and the patient is in the shock. You have to differentiate between these, the hyperdynamic LV. That can cause an LVOT obstruction. You can see your dynamic LVOT obstruction, because most of the 20 to 30% of the patient, septic patient, have dynamic LVOT obstruction. 2 से 3 supports चल रही होती हैं, and you have been asked for the patient has a 60, 70, 80 का pressure है जी, अब और कौन सी support चलाएं? Patient doesn't need all the inotropes. They probably you only give proper fluid and fill the patient will go out of the shock. So the next, more important, the pitfalls, I just want to mention that major problem with the LV ejection fraction is that reduced afterload by distributive shock, vasodilation, it's a pseudo-normalization of a decreased ejection fraction. So you have to come out of your ejection fraction and M mode and Simpson methods. MAPC, again, you will not get the proper view, but MAPC is a relative robust prognostic factor of mortality. Index MAPC over L less than 0.14 is a poor man, suggestive of reduced global longitudinal strain. In all septic patient, in all ICU patient, ventilated patient, you may not get a proper view to have a proper strain images. Remaining. So I will not go into the detail of the strain imaging because patient might not get a proper view. RV function, again, the septic patients with right ventricular dysfunction exhibit increased mortality as demonstrated in the study of 393 ICU patients, where the 28-day mortality was 31% in those with RV dysfunction and 16% only when without RV dysfunction. I will not get into the detail of the diastology because diastology remains same as in the normal patient. Another modality, which is systemic vascular resistance, you should be calculating in a sepsis patient. Simple formula of mean arterial pressure minus CVP over cardiac output into 80, and the normal value is 800 to 1200 dynes per second per centimeter. This also is you can say that occurs when sepsis-induced myocardial dysfunction implicates the initial vasodilation. So my conclusion is recognition of the 5 hemodynamics responses. You can see our hyperkinetic profile have a 23% characterized by supernormal LV. You can see right ventricle failure, a critical finding of the right dysfunction, LV ventricular systolic dysfunction, persistent hypovolemia, absence of the cardiac dysfunction. And there's some reversibility you can, because typically the septic cardiomyopathy, they have a global dysfunction rather than a focal changes or segmental wall, ventricular dilatation. So advanced metrics, So for patient in septic shock in 2025, a single echo snapshot is really sufficient. I believe that will Thank you so very much.